I'm Michael Davison, Managing Director of First Aid for Sport, and this is the DonJoy Armour ACL. DonJoy Armour is their top of the range ACL knee brace that's off the shelf. The only thing that's slightly different is the Defiance, which is their custom brace, but the Armour actually, if it fits you, is one of the best braces that I think we've ever had the pleasure to sell, fit to people and use myself. It's a super strong aircraft grade aluminium frame. It's absolutely ridiculously strong. It's a little bit heavier than some of the other DonJoys just because the frame is so strong. It's got a little bit of bling. They've chromed up their full force hinge, their force point hinge, sorry, on both sides, so it looks nice. Full force hinge is, we can't really show you, we'll do another video to show the workings of the hinge, but it's all adjustable in here, and the condyle pads come off. All of the pads on the Armour are replaceable. It works on DonJoy's 4-point principle. All the straps are numbered. Really simple brace to put on, but it's really important that you put it on right. So when you're undoing the straps, tip that we use at First Aid for Sport is when you're taking them off, stick this back down again. Just makes life easier. On the back of each of the pads there's just a comfort strip, which is a bit of chamois leather with Velcro on it. It also stops the brace slipping and moving. So, one more. So, really simple brace to put on. You simply put your leg right through the brace and then lift the calf up. The hinges need to be higher than you naturally think. So if you run your little finger down your knee, top of your kneecap, and the hinges want to be somewhere middle of the hinges want to be in line with your little finger. So much higher. The amount of people that come to us after buying one of these saying they're incredibly uncomfortable, and they walk in and it's down here, which is never going to fit, because when you actually bend your knee, it actually bends up here. So you've got to get it right to start with. So much higher than you think. Start with number 1 at the bottom. So to get it right and comfortable the first time, you can take off the pads, feed it through. They need to be tight enough to hold it up. Like me, if this is too long, you simply undo it, back of the brace. This is all adjustable, so you pull it a bit longer, redo the padding, try again. So that's number 1. Number 2 is up the top of the thigh. So push the frame down, do it up. So check how it's feeling. Number 3, back of the lower thigh. Again, this will need adjusting for me. So it may well be that I have to cut it slightly, which is absolutely fine. Feed it through. And when you do this one up, number 3 up, you'll feel it pulling the hinges down, which is absolutely meant to do, and it's fine. Number 4, there's an internal cuff, so you pull the cuff over, Velcro it down, and then on top of the cuff there's another Velcro strap that goes through and just pulls tight, and that's number 4. So there's your 4 points, and that's Armour's then in place. And what you want to then do is just walk around with it, feel how it fits on your knee, And when you take it off, if you've got red spots or real sore points, you just want to then adjust it, see how it feels. But that's the Donjoy armour with force point.
Hinter der Michelangelo-Hand verbindet sich die am weitesten entwickelte myoelektrische Armprothese der Welt. Ein Armprothesensystem, was wir in einer Entwicklungsarbeit von über 10 Jahren entwickelt haben, was aufbaut auf knapp einem halben Jahrhundert Erfahrung in den myoelektrischen Armprothesen.
Ich stehe aktiv im Leben, mache viele Hobbys. Ich bin Imker, also betreue Bienen, gehe klettern, Mountainbiken, Snowboarden, Skitouren. Also ich stehe eigentlich mitten im Leben und fühle mich eigentlich selbst persönlich überhaupt nicht behindert.
Und das C-Brace, eben das erste mechatronische Orthesensystem, das es Teilquerschnittsgelähmten wieder möglich macht, zu stehen und langsam zu gehen. Und ich habe gerade das Gespräch mit einer Patientin gehabt, die hoch emotional ergriffen über ihren Versorgungserfolg und ihre neue Mobilität und ihre neue Unabhängigkeit gesprochen hat.
Also mit dieser Orthese hat sich mein kompletter Alltag wieder verändert. Sei es jetzt wieder schön mit dem Hund rausgehen, über Felder und Wiesen zu laufen mit der kleinen Maus. Und zum Beispiel das Einkaufen kann ich jetzt auch schon wieder selber machen. Und vorher war ich ja immer abhängig und jetzt bin ich halt wieder unabhängig mit dieser Orthese.
Es ist mikroprozessorgesteuert, es ist ein mechatronisches System, das über eine Hydraulikeinheit und über Sensoren das gesamte Gehverhalten der Orthese und damit des Anwenders unterstützt.
Die erste mechatronische Beinprothese der Welt, die alternierend auch treppauf gehen kann. Ein riesen Innovationsschritt für die Beinprothetik.
Essa é uma joelheira steel joint desenvolvida como proteção individual de trabalhadores. É um brace articulado, fabricado em PAD, moldado a frio para manter as características do material, fixados internamente por EVA siliconizado, garantindo autofixação e conforto, fixados na perna por 2 elásticos com regulagem, e oferece um sistema exclusivo steel joint de fixação patelar no brace superior e inferior, que faz com que ela se mantenha no joelho mesmo em impactos mais extremos. Leve, fácil de colocar, oferece alta funcionalidade, oferece uma leve proteção contra ligamento colateral medial e lateral e uma alta proteção de impacto na patela que dissipa o impacto da patela para os braces superiores e inferiores, diminuindo em até 70% a sensação de impacto. Pode ser usada facilmente em cima da calça ou do uniforme de trabalho ou diretamente na pele. Essa joelheira é ideal para trabalhadores que trabalham durante muito tempo ajoelhado, aliviando quase 90% a sensação de pressão no joelho.
Your work as a physical therapist with an above-knee or below-knee amputee will be designed around what you want to accomplish with the patient before he is discharged from your care. There are several major goals to be achieved. The patient should understand the importance of proper stump care and hygiene. And the same with bandaging. He should be able to demonstrate proficiency in wrapping his stump. Your program will have taught him to walk with crutches without his prosthesis, smoothly, skillfully, and with a minimum of wasted effort. He should have developed adequate range of motion of the stump. And you will expect him to be capable of applying his prosthesis independently. His muscles should be strong enough to function with his prosthesis. Finally, he should be comfortable in ambulating with a correct gait while wearing the prosthesis. The first phase of your work with a new patient is, of course, the pre-prosthetic care. We'll first consider the above-the-knee amputee. A major aim of physical therapy is to prevent joint contracture. Early recognition and correction of undesirable positions is essential. If contractures occur, it will make the later work much more difficult for you and delay the rehabilitation of the patient. Early in the post-operative period, the patient is given instructions in bed positioning. He should stay in the prone position as much of the day as he can manage. It may not be a comfortable position for long periods, but you should emphasize to him how important it is to prevent contractures. If the patient insists on propping his stump, prop it in extension, not flexion. For periods throughout the day, it should be positioned in extension to stretch the hip flexor muscles. Make sure also that he keeps his stump adducted and internally rotated to prevent abduction or external rotation contractures. The object of stump bandaging is to both shrink and shape the stump. Briefly, the key points are these. Utilizing oblique and overlapping turns, exert slightly more pressure distally, slacking a bit as you work proximally. Wrap the bandage high into the groin to prevent an adductor roll. Anchor the bandage with the hip positioned in extension, not flexion. Cross the bandage in back, not in front, so that the stump will not tend to be pulled forward into flexion. To assist you in the planning of your treatment program, an evaluation of the patient is necessary. From early on and throughout the course of treatment, you regularly evaluate and record the range of motion. You also keep a record of stump girth measurements. The patient will not be ready for a prosthesis until the stump girth has stabilized or matured. Another assessment is done of muscle strength, utilizing various standard test positions. Keeping records on each of these evaluation techniques gives you a basis for planning and monitoring the treatment program. Once evaluated, a regimen of active and active assistive exercises aids in maintaining joint range of motion and strength of the remaining muscles. These exercises can be done in a variety of different ways. Here is an example of a hip abduction exercise which is important to prevent a gluteus medius limp. And here's an example of a hip extension exercise. This exercise strengthens the gluteus maximus muscle and aids in preventing a hip flexion contracture. Full excursion of active hip flexion and abduction range of motion should be deferred until the severed muscle groups have sufficiently reattached. There are some significant differences in the pre-prosthetic care of the below-knee amputee. In a misguided effort to make the patient more comfortable, well-meaning others will occasionally malposition the amputee. The optimum bed position for the BK patient is flat on the back, with legs together, but without support under hip or knee. The highlights of bandaging the BK stump include these points. Utilize spiral rather than circular turns, again, exerting slightly more pressure distally. Secure the bandage above the knee and enclose the femoral condyles as they are contained within the prosthesis. Leave the patella exposed to allow knee motion. With either type of amputee, don't forget to teach as you work. The patient must learn in time to do everything for himself, and it's your job to help him acquire the techniques. The BK amputee is started on exercises soon after his amputation. This isometric exercise for maintaining tone in the quadriceps muscle may be initiated from the first day. Approximately 3 days post-surgery, he is ready to begin mild, active range of motion exercises. He works toward achieving full knee extension and a normal range of motion. In some treatment centers where a rigid plaster dressing or an immediate post-operative prosthesis is applied, these early active exercises as well as stump bandaging may be restricted. Both the AK and the BK patients advance to resistive exercises as their stumps mature. There are several ways this can be accomplished. The resistance can be applied by you, manually. It can be applied utilizing the patient's own body weight. Or it can be done mechanically. Resistive exercises build strength in the remaining muscles. During the pre-prosthetic period, you will also be teaching the patient about stump hygiene. He needs to understand that he is to inspect and cleanse his stump sock, and his prosthetic socket every night, and do it with care. A nightly routine of stump cleansing with a mild soap is important. The patient should rinse and dry the skin carefully and completely. It's essential that he keep the skin in good condition. A rash or skin irritation will keep him from wearing the prosthesis. In addition to exercises for strengthening the stump musculature, you also need to be concerned about general body conditioning exercises. This is more than just a matter of good physical therapy. The opposite leg and the arms have to be strong for walking with crutches. Instructing the patient in the use of crutches is yet another pre-prosthetic activity of the physical therapy department. The patient should be reasonably comfortable, strong, and skilled with crutches before being allowed independent ambulation. Practice in hopping should be addressed, as many patients find this method of ambulation more convenient for short distances. This prosthesis for the AK patient is a quadrilateral, total contact suction socket prosthesis. It is suspended by both muscle contraction and a negative air suction. On this device, the knee unit is hydraulic. Friction types are also used. It's called quadrilateral because of the shape. This is the ischial seat, the major weight-bearing area, the medial rim, the channel for the adductor longus and gracilis muscles, the scarpus bulge, which forces the stump back onto the ischial seat. As part of acquainting the patient with the device, take time to explain first-level maintenance, such as cleaning the valve seat, and the socket. And make sure he understands that he must not try to make any changes in the device himself. Occasionally, a patient will try to remedy a discomfort by going at it with a file. The amputee must learn to apply his own prosthesis. After the first application, you check the fit. There are a number of items you want to evaluate during your prosthetic checkout. See that the stump makes total contact with the end of the prosthesis. There should be no air pocket inside. Around the top, there should be an appropriate amount of skin tension. A roll of flesh above the rim indicates improper seating of the stump. Feel the medial rim to make sure that it isn't too high. The adductor longus muscle should be located in its channel for proper rotation alignment. The tuberosity of the ischium should ride on the ischial seat. Check its position by having the patient lean forward. You then palpate as he straightens up. Is the pelvis level? An important question. With his weight evenly distributed, see if the anterior superior spine of the ilium is the same height on each side. Finally, is the anterior wall too high? If he can sit comfortably, the height is acceptable. At hospitals where specialized X-ray equipment is available, you can obtain plates like these to help evaluate the fit. Major points to be considered are the position of the ischial seat, acceptable height of the femoral heads, equal femoral adduction, and total contact at the bottom of the prosthesis. This X-ray, for example, reveals that the tuberosity of the ischium is off the ischial seat. Also, note the position of the head of the femur with respect to the grid line. On the other side, it is not in the same position. The prosthesis, in this instance, may not be the correct length. An inadequate femoral adduction angle, a major contributor to gait deviations, and a lack of total contact as evidenced by this air pocket are other criteria readily checked by X-ray evaluation. With the patellar tendon-bearing prosthesis for the BK patient, the weight is borne in the pre-tibial area. The socket will be set in slight flexion. This is the popliteal bulge, which forces the stump forward onto the weight-bearing area. On the first application, check these items of fit. When sitting, the cuff suspension should be loose enough for comfort. Check the height of the posterior wall by making sure you can get a finger over the rim to be certain it's not choking the stump. When standing, the cuff suspension should be taut. The upper rim should bisect the patella for proper seating of the stump. A level pelvis indicates appropriate length of the prosthesis. Throughout this stage, and until the patient has become ambulatory with the prosthesis, he should be continuing to use the bed positions described earlier to avoid the inadvertent development of joint contractures. Training with the prosthesis begins with balancing drills, which build the patient's confidence and his skill. One early drill involves shifting the weight laterally, and another, shifting his weight backward and forward. A third balancing drill uses a stepping motion, shifting the weight both forward and laterally onto the prosthetic leg. It's essential that you work closely with him on these drills. Two basic gait training skills must be mastered by the AK patient. First, he must learn to step so that heel strike occurs just at the end of the swing phase. And second, he must learn to lock his knee by extending his hip for support during the stance phase. The BK patient does the same balancing drills, but requires a different stepping action. First, the PTB wearer must learn to bear weight on a slightly flexed knee and to control knee flexion from heel strike to mid-stance. Second, while keeping the foot flat in mid-stance, he must learn to control knee extension. In time, the patient progresses from walking in the parallel bars to walking with the support of crutches. Then, to walking with a cane. And finally, to walking unaided. Throughout this training period, you play a vital role, carefully watching his gait to ensure that he is not forming bad habits. As soon as he's able to walk unaided, he performs for a small, select audience. This is a gait analysis using the clinical team approach. The audience is made up of the physical therapist, the physician, and the prosthetist. Each, from the vantage point of his own expertise, observes for any faults in the walking technique or the prosthesis. Again, it's essential to catch any problems early so corrections can be made before detrimental patterns develop. Once the walking gait has been successfully mastered, the patient goes on to advanced functional exercises. On stairs, the AK amputee usually ascends 1 or 2 at a time, whereas the BK patient can go up in the more normal step-over-step manner. Both types of amputees descend stairs step over step, but must learn to place the foot so that the edge of the step is just in front of the heel. This compensates for limited ankle dorsiflexion. Certain advanced AK patients can develop the skill to ascend stairs step over step. Other advanced exercises include ramp walking and the techniques for falling and for getting up again. And for getting places in a hurry. Your work with the patient does not end with your functional checkout nor hospital discharge. You should arrange at least one post-discharge follow-up conference. This gives you a chance to make sure that he is following a strict hygiene regimen and is getting proper exercise. Patients will vary in the kinds of activities they can return to. Many patients will find they can still do things they thought they would have to give up. And for some, even active sports like gymnastics and skiing will again be possible. With modern medical technology and the expert help of the physical therapist, lower extremity amputees will return to most of their former activities and will continue to enjoy the quality of life.
It's Booty Quake here from RollerDerbyAthletics.com, the place online for derby-specific training advice. I've actually adapted this workout from a study that was done on female soccer players. They put 1,300 athletes through this program and they were able to show a 41% reduction in ACL injuries, so it's really significant. I really want to encourage you to visit the blog and read the entire post that goes with this video, because in it I'm going to explain how you can adapt these and add these moves into your regular derby routine. The program consists of 5 sections: a warm-up, strengthening, plyometrics, agility, and then stretching. This is cool because we kind of need to do all of these things anyways for good derby fitness. The whole thing takes about 20 minutes start to finish, but if you read the blog, you'll see how you can pick elements and add them to what you're already doing with your derby training. All you need to do this workout are a timer, just any old regular stopwatch will do. I like to use the timer on my phone, and a rolled up hand towel. Okay, so the first step is warm up, and I've already just done that. If you do about 90 seconds, I did some jogging in place, some high knees, some bum kicks, and some jumping jacks. Whatever you do for 90 seconds, make sure that it has some aspect of lateral movement to it. So jumping jacks are good, or you could do some kind of stepping like that, or if you have more space to work with, obviously go nuts. So we're gonna go straight into part 2, which is strength. Now the first exercise is walking lunges, which are really hard to do in a small space and on camera, so I'm gonna have to modify a little bit. But here's what it's gonna look like. You're gonna lunge forward with your left foot and into a low, deep lunge. Now you want to have your front shin vertical and you want your back thigh vertical, okay? So you don't wanna be stretched out like this with your back leg, and you don't wanna have your front knee too far over your heel, over your toes, okay? So try to be in this position. So what you're gonna do is you're gonna step down into that position and then up and then keep going with the other foot, and then I'm off screen and keep going, okay? So again, making sure that as you go down, your knee tracks straight front and back over your toe, and you don't want to see it cave in, okay? So don't lunge and let your knee cave into the center. And as you lunge, try to watch and make sure your knee isn't going wibbly wobbly all the way down. You should go a nice straight line, okay? So that's walking lunges, you do them for 30 seconds. So the next thing is calf raises, and you're gonna do this on one foot, okay? So stand on one foot, lift up the other knee, hold onto your ear, because I find that that gives you really good balance. I don't know why, but it works. Okay, and then just rise up and down, up and down. Okay, so this is definitely gonna test your balance. Tuck in your core, pull that in if you're having trouble balancing. Okay, and just up and down. You're gonna do 30 on the first foot, 30 on the other foot, and then you're done. We're moving on to part 3. For part 3, you're gonna need your rolled up towel. This is the plyometrics section. Plyometrics basically just means jumping. Okay, so the first thing is lateral hops on 2 feet. Okay, so you've got your rolled up towel, you just put it on the floor next to you, stand on 2 feet, and you're gonna jump over it back and forth, side to side for 30 seconds. Okay, so it looks like this. Second one is forward and backward hops. So just as that would suggest, you put your towel down and you're going to jump forward and backwards over it. Okay, I'll do it sideways so you can see. With the whole plyometric section, you want to make sure that you have soft knees and you're landing on the balls of your feet. The next one is lateral hops on 1 foot. So yeah, it's pretty obvious and a lot harder. Okay, you'll do 30 seconds on your right foot and then 30 seconds on your left foot. So notice that when you've got the towel there, you've got something raised, you really have to pick your feet up to get over it. So that's super great for agility practice for roller derby. The last one in plyometrics is lunge jumps. We're gonna do these for 30 seconds as well. And we're gonna use the exact same form as the walking lunges. So a nice straight knee that isn't caving into the inside. Keep your back knee also kind of right in a vertical line with the rest of your body, with your hips. Okay, so you're going to get into a lunge position and then you're going to jump and switch feet. Like that, okay? So this one is definitely a little bit tricky with balance sometimes, so use your arms to help you. If your left foot is forward, then your right hand is forward, and then you switch, switch, switch. The fourth part of the system is called agilities and involves a bit of running around. So I'm not going to do that on the video. I'm going to let you read about that on the blog, and that's something that you could incorporate into your pre-skate, off-skate warm-up, or after practice with your team when you've got a little bit of space to run around in. So straight to 5, and 5 is stretching. All right, the first stretch is a calf stretch, and we're gonna do this kind of like a bit of a downward dog kind of style. Just walk your hands out in front of your feet to a comfortable spot. Put your feet together, and you're going to bend 1 foot and stretch out the other one, and put your heel, so I'm putting my right heel on the ground right now, and the right leg is the one that I'm stretching. And if I lean back a little bit further, I get more of a stretch. And then you'll switch legs and you'll hold that stretch on each foot for 30 seconds. Next up is a quad stretch. So I'm pretty sure you guys all know this one. Hold onto your ear for balance. And you should be able to touch your heel to your bum. If you can't, then that's a sign that your quads are too tight and you need to spend more time stretching your quads. 30 seconds, switch legs, 30 seconds again. Figure 4 hamstring stretch. So you are going to stretch 1 foot out in front of you, pick up your other foot and cross it over the outstretched knee, and flex that foot because that protects your knee from injury. And then with a straight back, lift up and lean forward over both your legs. Okay, then we're gonna do an inner thigh stretch. So do a little side split action here. Stretch your legs out to wherever's comfortable for you. I happen to be really flexible, so don't let that bother you. And you're going to lift up and with a very straight back, reach forward. So you just walk your hands out to where it's comfortable. And you're gonna hold that for 20 seconds. Then you're gonna take your right arm over to your right foot and your left arm over. And just like a ballerina, do that one for 20 seconds. And then switch to the other side. In that lunge position, you're gonna keep really nice square hips and just lean forward. You want to make sure that your hips stay forward, kind of like if you're on a mat like me, that your hips are square with your mat, so you're not opened up like this, okay? Square hips, 30 seconds on one knee, 30 seconds on the other, and then you're done. That was the Happy Knees workout. I would really like to hear from you about what you'd like to get out of these videos and the blog. So I hope you'll do me a favor and go over to rollerderbyathletics.com and leave me a comment below this video and let me know if there's another area that's injury prone that you would like some advice on. I'm Booty Quake, and I wish you a season full of happy, healthy knees. Ciao.